So this morning, let's start off with a couple of very simple definitions just to clarify those. Routine testing simply applies for any healthcare visit when testing is done. The exceptions then become if you're doing a test in an individual who has clinical signs and symptoms which suggest to you HIV, and you do that test to make a diagnosis. Screening in general is performing an HIV test for all persons in a defined population, and then targeted testing really is performing that HIV test for specific populations of individuals who you perceive to be at higher risk, and that is often based on other characteristics such as behavioral characteristics, clinical or demographic situations. Additional definitions are just informed consent. That's the process of communication whereby we inform the patient so that they in fact can choose whether to undergo a test or not, and obviously in this case HIV testing. Opt-out testing or screening is performing the screening after notifying the patient that the test will be performed and that the patient may elect to decline or defer testing. Assent is inferred unless the patient declines testing. HIV prevention counseling is specifically an interactive process, really trying to assess risk in an individual behavior, helping them recognize specific behaviors that may increase their risk for acquiring or transmitting HIV, and really formulating a plan with that individual to take specific steps to reduce their risk. Why are we talking about perinatal HIV? Because in Florida, HIV continues to be a significant problem. You can see here the new cases. You can see that 32% of the AIDS cases reported occur in children 13 and older. And HIV remains, at this time, the 5th leading cause of death in women aged 25 to 44. 92% of women report heterosexual contact as their mode of transmission. And in 2010, 1 in every 284 adult women were in Florida were infected with HIV. Additionally, we know that women are more susceptible than men during unprotected heterosexual intercourse. And then there are a variety of factors which clearly can contribute to the transmission of HIV. Clearly, other STDs can increase the risk. The stage of disease or illness in the contact partner will change that risk. If there's substance abuse by either partner, that can increase the risk. Age, various social behaviors can alter the risk, and then contraception may play a role in terms of the contraception used, as well as very specifically the exposure site being a very important aspect to changing the risk of transmission in different situations. Obstacles at this time that we continue to see across the United States, including in Florida, that are limiting our ability to prevent perinatal transmission include the following. There continues to be the increased HIV infection in women, particularly of childbearing age. Many women do not receive prenatal care, particularly if they use illicit drugs, often if they have mental illness and that prevents them from receiving prenatal care, or if simply they don't believe or try to access care. Acute infection, late in pregnancy, and in women who are breastfeeding continues to be a significant risk. That primarily is because the viral load at the time of primary infection is so high in the mother that dramatically increases that risk of transmission. Poor adherence to antiretroviral regimens continues to be a barrier and is an important aspect of the efforts to prevent transmission. And then finally, lack of full implementation of all the steps for HIV counseling in the prenatal period, and then routine and universal testing for pregnant women. Our lack of being able to do that fully in every woman across Florida continues to be an issue for us. HIV and STD testing in pregnancy, now there is Florida law since 2006, That Florida law was based on a number of agencies and groups recommending it. Obviously, the CDC recommended it, but also ACOG, the College of Obstetrics and Gynecology, recommended it also, as did the American Academy of Pediatrics, and AWHON's position statement all contributed to the formulation of this Florida law. The Florida law recommends prenatal testing and specific requirements, suggesting testing for STDs, including chlamydia, gonorrhea, hepatitis B, syphilis, and HIV at the first perinatal visit, to repeat that testing at 28 to 32 weeks gestation, and if there's no documented result after 28 weeks, to do rapid testing when the woman is in labor or within the first 30 days postpartum. That rapid testing is clearly another resource for us to be able to get a timely result in a woman when we still could intervene to try to prevent perinatal transmission. Notification of testing is sometimes an issue that practitioners struggle with. They're worried about what the person will say. They're worried about what the results might be or the discussion. But particularly when you're offering the test, you're simply stating what tests will be conducted. You'll inform that woman of her right to refuse any and all tests. If she does refuse, you ask her to sign a statement of objection and specify in that statement which tests were refused. And if she does refuse or is unable to sign, a very brief 1 or 2 line sentence documentation in the medical record is appropriate. Education and HIV testing for the pregnant women, quote, as a best approach, obviously we would do this from a professional perspective, always considering cultural issues and trying to remain culturally sensitive. We hopefully will remain non-judgmental, and obviously all of our communication with patients should remain confidential. We should offer it to every patient. There are no exceptions to that. There's no reason to say there's an exception. And the statement of we routinely test all pregnant women, or we routinely test patients for HIV and STD unless you tell us not to, is the phraseology that's very appropriate and very well accepted by most women in terms of offering them testing in the opt-out format. Women and patients in general listen to what clinicians say and what clinicians recommend. And your simple statement that we routinely test for HIV and STDs is a statement that you recommend it, and it is important. And then you will see if there are objections to that. Given that testing, if there's a question or a consideration that the woman might refuse it, it is appropriate to tell her that we clearly have interventions which can protect their child. The pregnant woman often wants to do many things to protect their child and have a healthy child, and we do have that ability to protect their child. And the Pediatric AIDS Clinical Trial Group, the original trial back in the 1990s, is part of the proof that we have that we clearly can prevent perinatal transmission. As you can see on the slide, at that time, zidovudine was used for all 3 arms, antepartum, intrapartum, and postpartum medication. The benefit from AZT was noted even though there may not have been a dramatic change in the viral load at that time. Part of that prevention clearly in the United States clearly includes no breastfeeding. And in the postpartum period when the infant is given medication, there is a well-documented dose adjustment that's appropriate for premature infants and is appropriate for infants who could only receive the medication intravenously versus by mouth. The 3 stages, antepartum, this is beginning medication in the mother at 14 to 34 weeks of gestation. At that time, it was AZT alone. In this era, it now would be HAART, highly active antiretroviral therapy. that would consider the other variables for the mother's health in terms of choosing a specific regimen. The interpartum continues to be zidovudine or AZT infusion through the period of labor and delivery, and one up until the delivery, and then postpartum specifically refers to providing the infant with AZT. Previously, there was a different regimen. As of 2011, the regimen is 4 milligrams per kilogram every 12 hours for 6 weeks. That's a decrease in frequency, making the administration to the infant much easier. And I can tell you that in almost 20 years of providing AZT for infants, I've only had 2 women say they couldn't give the medication or the infant wouldn't take it, and both of those were women who were not complying with their own regimen of medication. This is more data for us about perinatal transmission prevention, and this is again from trial 076. Clearly, the transmission rate was as high as 25% in the placebo group, and in the group that received zidovudine decreased to 8.3%, a 2/3 reduction in the risk of transmission. And a Kaplan-Meier plot of that data also was significant, down to a p-value you can see there of 0.00006. Very, very significant. This picture should show us a graph of the transmission rates of perinatal HIV in Florida by year of birth. The purple dot you see highest there. On my picture, I actually can't see the drawn line, which should increase up to here, where the peaks were here in 1993 to 94, and then the line started to drop down along these subsequent dots. And clearly the rate in Florida back in 1993 was over 175 cases per year of perinatal transmission. That is, infants who were clearly HIV positive via perinatal transmission. The various interventions using the format of 3 stages of prevention: prenatal, intrapartum, and postpartum, as per trial 076, gave us that initial drop in the rate of transmission, and then the release of guidelines so that this prevention model was used in more and more locations occurred here, and then again here it was reinforced, and the curve through this time period is dropping. Mandatory testing became law, and so we saw a continued drop, and then as we go out to the 2000s, it has continued to gradually decline. Let's see if on the next slide you can see that full curve, or if I can show you some other data. So here's the data from 2007 through 2012, and the locations around Florida are indicated by the various symbols there. And what you can see on the far left-hand side is that in 2007 there were 17 infants infected by perinatal transmission, and that has continued to decline through 2011. Most recently in 2012, one would say that there was a slight jump back up, and this is clearly an additional reason why we should be talking about this today, and why we should continue to talk about this and not forget it, because if we do, we will see these numbers go back up. This slide should show us the natural course of HIV infection and common complications. Why are we showing it at this point? The reason to show it is during acute HIV infection, the viral load spikes up to its highest point throughout the whole rest of the infected individual's lifetime, and then gradually goes down in the first several months after infection, and usually reaches a relative set point in an individual, during which time most of them are asymptomatic. And then out here, that viral load never goes back up as high as it does during that primary infection. Why would I reinforce that at this time? Because primary infection in women who are pregnant in the second or third trimester after they've already been tested negative in the first trimester is one of the significant risks for continued perinatal transmission, not only in Florida but across the United States, as well as primary infection during breastfeeding. If a woman is breastfeeding, would also put that infant at significant risk. The clinical picture of primary HIV, for those of you who have seen it, it only occurs in a very small percentage of all the individuals who are HIV infected, and yet these are some of the symptoms and signs that you would see in a individual who has primary HIV infection. Why put this up here? If you are working with women or have contact with pregnant women or any woman, and this was the symptomatology, and you then had a discussion with that woman about the importance of HIV testing as part of, quote, routine testing, or in the case of the pregnant woman, as is recommended for all pregnant women, then you would do the testing or repeat the testing at this time. When you suspect primary HIV infection, the only difference is you would test using viral load. If you have a fourth generation antibody antigen test in your facility or in your hospital, you would use that antigen antibody test, because that new generation test is very sensitive and can detect antigen down to as early as 14 to 17 days after infection. This is just to remind us about the HIV life cycle and the various medications and where we might interfere with viral replication. So keeping in mind primary infection at very high viral load, and keeping in mind that the Florida law recommends that we test in third trimester, these 5 cases are just, or these 4 cases are just an example of the failure to prevent HIV because of not retesting in the third trimester. And you can see there from those 4 different women of varying ages that clearly infection occurred during pregnancy, and the lack of testing in the third trimester is what led to us not knowing that woman was infected and not being able to offer perinatal HIV prevention, even if it was initiated in the third trimester or at or around the time of delivery. There is a clear benefit still to the infant. Initiating antiretroviral medications during delivery or simply in the infant postpartum can decrease the risk to that infant by almost 50%. And finally, Dr. Helfgott, in his study looking at third trimester testing or rapid testing late in the third trimester or at the time of delivery, he noted that almost 72% of the tests that they did at their facility were because no third trimester test was done. And I'm going to tell you a little bit more about Dr. Helfgott's test or publication in just a minute. Given all of that testing, we then, and the possibility that we will identify women who are HIV positive, we also have to consider the care of the woman, not only in the postpartum period, as we're going to talk about here, but also in the during pregnancy, with the importance of her receiving HIV specialty care, continuing her primary care, as well as continuing her obstetrical care in the prenatal period. All of those should continue in the postpartum period. Many times women focus on the child's health and don't focus on their own health, and it's very important for us to reinforce this with women, reinforce that they continue to follow up with their caregivers so that their health can be maintained regardless of their HIV status. Additional important issues are mental health and substance abuse treatment. I mentioned those early on as risks because of the lack of prenatal care in many of those individuals, but also those conditions can influence the mother's ability to comply with antiretroviral therapy during this time period, separate from the fact that substance abuse may increase the risk of perinatal HIV transmission. And then finally, We should coordinate care via case management for the woman and for her family, and that includes support services for the whole family, whether that's the partner or whether it's the newborn infant and other children in the family. This brings us back to Dr. Helfgott's study published in 2006, and he practiced in Pensacola, Florida. And over about a year's time period, he looked at or reviewed over 3,500 deliveries in their labor and delivery area, and they performed over 1,800 rapid tests done on L&D. They additionally reviewed over 600 charts to find additional data and other additional clarifying data. What they found was the reasons for rapid testing at delivery, again, almost 3/4 of them were because there was no third trimester test. Others, there was no prenatal care. They declined testing previously. The results were not available at the time of delivery, or they were simply being retested at the time of delivery. And some women even reported that they were never offered the test. Out of that, they identified 2 women who were confirmed to be HIV positive. Interventions initiated at that time were both successful, and that both of those children of those women subsequently were seronegative. There were 2 false positives which were subsequently proved by Western blot. And in those infants, although zidovudine was started, it was able to be stopped in a timely fashion because of the confirmatory testing. In part, we've been talking about not just recommendations for Florida, but these would be national recommendations for HIV for testing of women. Again, routine HIV screening is appropriate for all pregnant women, and we should use the opt-out approach in all situations. Rescreening should occur in the 3rd trimester, and if results are not available or testing was not done in the 3rd trimester, then in labor and delivery, rapid testing is appropriate at that time for any woman whose HIV status is unknown. And then finally, postnatal testing can occur both in the mother or the infant in women whose HIV status persists to be unknown if rapid testing was either not available or not available in a timely fashion prior to delivery. There are well-reviewed and well-worked-out guidelines for using antiretroviral medications in pregnant women. We are not going to go through all of those. We provide these resources so that you could refer to that and look at that. As a practitioner in northern Florida and seeing children who are HIV exposed, we do submit to the antiretroviral pregnancy registry all of the data on any child who's born here in northern Florida and Gainsville to the registry. And part of why we do that is we want to continue to have information on the use of antiretroviral medications in women, the safety of those not only in the woman but also for the fetus and infant. Another question that often comes up is the question of cesarean section. And this slide talks to us about a meta-analysis of 15 prospective cohort studies involving over 8,500 women. In that meta-analysis, elective C-section, meaning that planned, controlled C-section with intrapartum zidovudine being given intravenously to the mother, and that C-section generally occurring at 37 to 38 weeks, elective C-section decreased the likelihood of vertical transmission by 50% compared with any other mode of delivery. Additionally, in mothers and infants receiving zidovudine for all 3 arms, C-section versus other mode of delivery still decreased the risk of transmission. In the cesarean section mother-infant pairs, there was a rate of only 2% versus 7.3% in mother-infant pairs who delivered by another method. That's pretty significant data to document the benefit of cesarean section. Having said that, that decreased risk of transmission to the infant via cesarean section is very important, but there are postpartum complications, and those postpartum complications are more common than occur after vaginal delivery. They are more common in women who have advanced disease or other significant medical problems. The risk of perinatal transmission based on mode of delivery when the mother has a viral load and whether we should recommend or consider that still remains unclear. I do not commonly recommend it when women have viral loads that have been well maintained, undetectable during pregnancy, and especially during the last trimester. And here are some of the risks that clearly are increased in HIV women who do undergo cesarean section. The risk for postpartum endometritis, the need for a blood transfusion, maternal sepsis, treatment for pneumonia in that mother, or maternal death. Each of those are at increased frequency in HIV-infected women who do undergo cesarean section. So as part of informed consent, if we're speaking to a woman about cesarean section and the potential benefits, we would need to mention these as potential risks. So in summary for today, I would like to remind you, so that we can all continue to remember this in terms of our efforts to prevent perinatal HIV transmission, opt-out testing should be the standard, and we should be very comfortable offering that and following through with that. It does constitute a recommendation to the pregnant woman or a non-pregnant woman that we recommend this testing and that it's very appropriate. We're not implying anything about our suspicion for them. We test all women for HIV during pregnancy. And at the time of initial testing, we should remind them that we will repeat this testing in the third trimester just as much as we should remind ourselves. And then finally, it's appropriate to be aware of rapid testing services that are available at your labor and delivery centers where you practice and where you share the care of HIV pregnant women. And you should know that availability and know that you can do it both prior to delivery or in the immediate postpartum period. And then we should not make assumptions about risk. We should be testing adults. That would be routine testing. We should also test and treat for sexually transmitted diseases, testing for cure after treatment, and also providing that treatment for partners. And then finally, it's very important to provide access to substance abuse programs or mental health assistance, because that will improve access to care or women accessing health care, but it will also improve their ability to comply with the antiretroviral regimen. Thank you very much. We'll go forward and entertain questions. Millie, were there any things that I said that you thought could be re-emphasized, or were there any points that, I know you do this work around the state, were there any other things that you thought were particularly important to re-emphasize at this point if we don't have questions?
Well, one of the things I think is so important, I love that you emphasize the idea that you present to the patient that they're going to have this testing and that it will be repeated again in the third trimester. I tell nurses and social workers in hospitals and office settings to remember that patients may deny the testing in the beginning, but as that baby grows, their tummy expands, it becomes much more a real entity to them. When you get to that third trimester, even though they denied the testing first trimester, they have probably changed their minds very often. I also think it's really important in a hospital setting that when you see that there's no testing or testing that was only done in the first trimester, that you do the testing again as a rapid test. These are things you've emphasized that I think are extremely important for us to make the greatest impact against transmission of HIV.
And clearly, it's appropriate from time to time to recheck with your labor and delivery facilities or your hospital or the lab associated with your hospital for what testing they have available in terms of rapid testing, what the turnaround time is, how do you order that and get that in a very timely fashion. And so the better you know what the situation is where you practice, the easier it is at the time of labor and delivery, when sometimes time is compressed and things are a little bit harried, you know exactly what you're ordering, you know exactly what you're asking, and you also know in what time frame will you receive those results, and so in order to act on those results.
These are the resources for the guidelines. We ask that you please, go ahead and check them. It is a multiple pages of guidelines, but they are being ever morphed into newer recommendations. So this is one of the reasons that we exist, is to make sure that everybody's on the most up-to-date protocols for their facility.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, fcaetc.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center Project ECHO provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.